Good evening, ladies and gentlemen. Today's lecture is on the clinical features of psoriasis and its different clinical variants. Symptomatology. Some time back, it was considered that psoriasis is a non-pruritic disorder. This is no longer true. Pruritus is present in patients of psoriasis, although it's not as severe as we see in atopic eczema. The other symptoms experienced by patients of psoriasis include the skin tightness and burning, which are the frequent symptoms in unstable erythrodermic or pustular psoriasis. Pain may be experienced in areas of fissure formation, particularly the Palmoplantar or Flexural disease. Shedding of scales contribute to feeling of embarrassment and difficulty in interpersonal relationships. The impact of disease and its symptoms on patients' relationships, activities, and occupation can be quite severe. Psoriasis may manifest at any age, and in general, those with earlier onset of disease are more likely to have a family history of psoriasis. The course of disease with relapses and remissions varies greatly between individuals. A detailed medical history should be taken for symptoms of common co-morbidities, particularly the articular symptoms. Plaque psoriasis. Plaque psoriasis is the most common form of psoriasis, which contributes to 80 to 90% of the cases of psoriasis. This variety is also called as psoriasis vulgaris or the common psoriasis. The typical lesions are red, scaly, well-demarcated plaques with sharply delineated edges. Plaques may be encircled by a clear halo, which is called as the ring of Voronov. Plaques can be single or multiple. Lesions are usually monomorphic and are distributed relatively symmetrically. Involuting lesions often clear from the center initially, producing annular or arcuate shapes. Linear configurations arise at the site of trauma, which is called as the isomorphic or Kovner phenomena. This is the ring of Voronov seen around the plaques of psoriasis. The color of plaques is often described as the salmon pink. Erythema may persist at the site of previously treated plaques for many months. The psoriatic lesions are surmounted by silvery white scales, which vary considerably in thickness. The amounts of scaling is minimal in the flexures. Removal of scale physically reveal an underlying smooth red membrane with small bleeding points. This is the Auspitz sign. Thickness of plaques varies between the patients and may predict the response to treatment. So, in summary, the psoriatic lesions are characterized by three features. Number first, thickness or induration. Number two, color, which is salmon pink. And number three, scaling, which is thick silvery scales. These three criteria are also the basis of PASI scoring of psoriasis. Scalp psoriasis. Scalp psoriasis is the commonest area which is affected in the disease, and sometimes is the first manifestation of the generalized psoriasis. Whole scalp may be diffusely involved, or there may be a few plaques or multiple discrete plaques. Plaques tend to be restricted to hair-bearing areas, extending a short distance beyond the hairline and around the ears. This is the feature which distinguishes psoriasis with seborrhea, in which seborrhea, the scales are usually soft and oily and are restricted to hairline. While in scalp psoriasis, the scales are thick, dry, and extend beyond the hairline. Alopecia due to psoriasis is rare, and psoriatic erythroderma is associated with severe hair loss, although this is telogen effluvium, and these hairs which fall, they return back after some time. There is a morphological entity that consists of thick asbestos-like plaques which are firmly adherent to the scalp and associated with thinning of the hairs. This type is called as the pityriasis eminentia and best regarded as a non-specific reaction pattern. Hair loss, sometimes cicatricial, is seen in this variety. Follicular psoriasis. Follicular psoriasis is a subvariety of psoriasis that affects the hair follicles on the trunk and limbs. The lesions of follicular psoriasis are typically smaller than guttate psoriasis and may be either grouped or diffuse. The histology of follicular psoriasis is similar to the plaque psoriasis, but it is limited to the hair follicles, and the hair follicles are characterized by plugging of the follicles by parakeratotic scales with associated Monro abscesses. And the follicular epithelium shows spongiform pustule of Kogoge and hyperplasia. These are the follicular psoriasis lesions. Sebopsoriasis or seborrhoeic psoriasis. This is a rather disputable term which include features of both seborrhea and psoriasis. The plaques are thin, sharply demarcated erythema, and variable scaling, distributed in the typical seborrheic eczema-like distribution, involving the paranasal areas, external ear, medial eyebrow, hairline, pre-sternal, and interscapular areas. Such kind of presentation may be seen with psoriasis elsewhere or without any evidence of psoriasis. Flexural psoriasis. Lesions involving the inguinal creases, axilla, submemory, gluteal cleft, or umbilicus can occur in patients with generalized psoriasis. So such cases, in such patients, these lesions are labeled as flexural psoriasis. Less frequently, psoriasis only involves the flexural areas, and no psoriatic lesions are seen on the extensor surfaces, which are the typical areas involved in psoriasis. So in such cases, the psoriasis is called as the inverse psoriasis. The lesions of the inverse psoriasis are thin, scaling are greatly reduced or absent, but because of hyperhidrosis, the lesion may be macerated. The color of psoriasis is, however, characteristically retained. The surface of lesion has a glazed hue and fissuring at the depth of skin folds. Involvement of napkin area may be the first presentation of psoriasis in infancy. This is a lesion of flexural psoriasis. You can see that the lesion is not as thick as the plaque psoriasis and the scaling is minimal. Such lesions have to be differentiated from intratriginous candidiasis, where the lesions are more glazed, macerated, and there are satellite lesions as well. While the lesions of inverse psoriasis are little drier and there are no satellite lesions and scaling is rather thin. Genital psoriasis. The genital skin can be considered as a type of flexural skin, and there are similarities between the flexural and genital psoriasis. Glans penis is the most frequently affected part. In circumscribed, the lesions are similar in appearance to the plaque psoriasis elsewhere. In uncircumscribed male, however, the plaques lack the scale, but the color and well-defined edge are characteristic. Sometimes we require a skin biopsy to differentiate these plaques from the erythroplasia or plasma cell balanitis. Patients with vulval involvement often complain of marked pruritus and should be considered in the differential diagnosis of chronic erythematous vulvitis without vaginitis. These are the lesions, typical lesions of plaque psoriasis on the glans and shaft of penis in circumscribed males. Non-pustular palmoplantar psoriasis. On palm and soles, psoriasis may present as typical scaly plaques or less well-defined plaques resembling hyperkeratotic eczema or pustulosis. It is often difficult to distinguish psoriasis and eczema, but thicker scale plaques, longer duration, and less response to topical treatment favor the diagnosis of psoriasis. Furthermore, in such patients, one should look for the typical nail changes of psoriasis, which will help in differentiating hyperkeratotic eczema from palmoplantar psoriasis. There may be a relationship to trauma or occupation in such case. These are the hyperkeratotic psoriatic lesions on palm and soles. Nail psoriasis. The nail changes are among the commonest changes seen in patient of psoriasis and attributes to 40% of the cases. Nail psoriasis is associated with more extensive psoriasis of longer duration with family history and presence of psoriatic arthritis. Psoriasis may affect the nail matrix, the nail bed, or the hyponychium. If psoriasis involves the nail matrix, then it may present as the pits, ridges, and grooves of the nail plate. If the psoriasis involves the nail bed, then it presents as subungual oil drop sign, subungual hyperkeratosis, or splinter hemorrhages. If psoriasis involves the hyponychium, it presents as distal onycholysis. Pitting is the most frequent change seen in the psoriatic nails, and pits are usually uniform in size, about 1 millimeter in diameter. So these are the three images of psoriatic nail changes. The first shows the nail pitting, second, subungual hyperkeratosis, and third, oil drop sign in the middle and distal onycholysis. Histology of nail psoriasis is similar to psoriasis elsewhere. The nail plate is taken as a stratum corneum, and you can see the parakeratosis in the nail plate along with Monroe abscesses. In the nail bed, there will be hyperplasia and spongiform pustule of Kogoch. So if you are taking a nail biopsy for psoriasis, you have to include the nail plate along with the nail bed. Mucosal lesions. True mucosal lesions in psoriasis are rare. However, geographic tongue or benign migratory glossitis is seen in patients with psoriasis, and especially it is seen in pustular psoriasis. Ocular lesions are uncommon in psoriasis and mainly attributed to the presence of psoriatic lesions on eyelid and eyelid margins. There can be a non-specific conjunctivitis, maybe keratitis, and sometimes uveitis. Then the clinical variants based on morphology and natural history. Acute guttate psoriasis. This is characterized by a sudden onset of showers of small lesions appearing diffusely and symmetrically over the body. Small plaque psoriasis or follicular psoriasis are never present acutely and have a more chronic course. Acute guttate psoriasis may be the first presentation in children and young adults. It frequently follows pharyngitis caused by group A streptococci. The lesions are from 2 to 3 to 1 centimeter in diameter on trunk and proximal limbs and infrequently on the face, ears, and scalp. Diagnosis is made chiefly on the nature of the lesions and evidence of preceding infection. Such lesions resolve in about 3 months, and a significant minority of patients subsequently develop the chronic plaque psoriasis. These are the guttate lesions of guttate psoriasis, and in the differential diagnosis, you would include pityriasis lichenoides chronicus, secondary syphilis, and pityriasis rosea. The histology is also typical. Rather than confluent parakeratosis, there are focal lens-shaped areas of parakeratosis with Monroe abscesses. Hyperplasia is not well developed as in plaque disease. Unstable psoriasis, also known as the active psoriasis or eruptive inflammatory psoriasis. In some individuals and in some phases of the disease, there is more marked inflammatory activity that manifests in form of sudden enlargement of plaques or sudden intense inflammation or development of many new plaques suddenly. So the sudden eruptions or sudden changes are important to label it as unstable psoriasis. Patient may complain of more pain or pruritus within the plaques. Koebner phenomena is thought to be more frequent. Lesion may return to inactive state or progress to localized pustular or erythrodermic psoriasis. Such patient may develop unstable lesions repeatedly. Known cause of unstable psoriasis is sudden withdrawal of systemic or potent topical corticosteroids, treatment with irritants like tar or dithanol, acute infections, hypocalcemia, or perhaps emotional upsets. Serum level of interleukin-17 and interleukin-1 are higher in patients of unstable disease. Erythrodermic psoriasis. Erythroderma is described as involvement of more than 90% of the body surface area. So in case of erythrodermic psoriasis, almost complete body is involved by psoriatic lesions, and this accounts to about 1 to 2% of psoriatic patients. In all cases of erythroderma, psoriasis contribute to 25% of the cases. Erythroderma in psoriasis can be chronic, slowly evolving, or can be acute. In such acute cases, it will be in the spectrum of unstable psoriasis. The acute form is often precipitated by systemic illness, alcoholism, antimalarials, irritating topical treatments, ultraviolet radiations, or by withdrawal of systemic corticosteroids, cyclosporin, and methotrexate suddenly. Mild topical treatments are well tolerated and overall prognosis is good. Patient can be febrile and systemically ill. Dependent edema is common and itching is a prominent symptom. When the entire skin is involved, then the typical sharply delineated plaques will not be visible. There will maybe a clinical overlap with generalized pustular psoriasis. Untreated, the course is prolonged, relapses are frequent, and there can be appreciable mortality. So the mortality is because of skin failure and all the other features of skin failure that include sepsis, hypothermia, hyperthermia, hypoalbuminemia, anemia, dehydration, and high output cardiac failure. These are the patients, images of patients with erythrodermic psoriasis. In addition, there are certain atypical presentation of psoriasis. For example, psoriasis limited to digits or interdigital clefts. Then verrucous lesions, which are called as rhipoid, elephantine, or ostraceous psoriasis. This is described about the plaques with gross hyperkeratosis. By rhipoid psoriasis, it is also referred as limpet or cone-like lesions, scales. Ostraceous psoriasis is referred to ring-like hyperkeratotic lesions which are concave in the center, like an ostrich shell. So this is an elephantine or ostraceous psoriasis. You can see that the scales are quite thick and hyperkeratotic as compared to usual psoriasis. Linear or segmental form of psoriasis is a rare presentation in which the only presentation on the body is in the form of linear lesions or the lesions limited to Blaschkoid distribution. Such kind of lesions are often severe and refractory to treatment. Phenomena should not be confused with inflammatory verrucous epidermal nevus or Koebner phenomena. In Koebner phenomena, there will be linear lesions along with other more typical lesions of plaque psoriasis. But in segmental or linear psoriasis, there will be only linear lesions. Psoriasis in childhood and old age. Psoriasis is common in children with a cumulative prevalence up to 18 years of 0.71%. Psoriasis in children are significantly associated with several comorbidities like obesity and diabetes. There is no evidence that onset of psoriasis in childhood predicts severe disease in adult life. Napkin area is frequently the first affected site and presenting as well-defined erythema without scaling. Guttate psoriasis is more frequent in children than in adults. Disease often first appear on the scalp, and sometimes the flexural form are first manifestation. Erythrodermic and pustular variant of psoriasis are rare in childhood. Parakeratosis pustulosa is an indolent and recurrent scaling pustular acrodermatitis, sometimes around the nail of only one digit. Psoriatic arthritis is uncommon in children. Inverse or erythrodermic psoriasis may be more common than in early onset disease, where guttate and generalized pustular psoriasis are rare. HIV-induced exacerbation of psoriasis. With the increase in prevalence of HIV cases, there is increase in exacerbation of psoriasis in such patients. And there is an association between severe psoriasis, psoriatic arthropathy, and HIV infection. Psoriasis may be the first presentation of HIV infection, as may the deterioration in stable disease. One suggestion is that although HIV affects the peripheral blood helper T cells, the disease affects the memory T cells to lesser degree, which are pathogenic in psoriasis. So psoriasis improves by decrease in viral load once the antiretroviral therapy is started. Classification of severity or the PASI score. There are neither validated nor clinically useful laboratory markers of activity of psoriasis which is currently assessed clinically. PASI score is most widely used in clinical trials and clinical practice, initially developed in 1978, and since then it is partially validated to be a score for severity of psoriasis. In PASI score, 4 different areas are examined. The first is head and neck, second is the trunk, third is upper limb, and fourth is buttock and lower limb. And there is a correction factor which is used, which is different for the different areas for the surface area involved in these areas. Then there are 3 things which are to be graded. That is erythema, scaling, and induration in these 4 areas with a total score ranging from 0 to 72. PASI score is not appropriate in form of psoriasis other than plaque disease, for example, guttate or pustular psoriasis, when a record of body surface area is sufficient. In general practice, physician global assessment may be more appropriate. This is a rough estimation of erythema, scaling, and induration in 5, 6, or 7 point rating score, which is labeled as clear, from clear to very severe, without the assessment of body surface area. This score is not a standardized score, but it's straightforward and easy to use and understand. The severity of psoriasis is also measured by Dermatology Life Quality Index, which is a validated tool used in clinical trials and clinical practice. This is a 10-point questionnaire that generates a score of 0 to 30, and scores of greater than 10 means that the disease have a significant impact on the patient's life. DLQI correlates only moderately with PASI because both measures different aspects of the disease. The first, the DLQI measures the effect of psoriasis on quality of life of the patient, while PASI score is a generalized measurement of involvement of body with psoriasis. Severe psoriasis is usually labeled as patient having a PASI score greater than 10 or equal to 10, DLQI of 10 or more than 10, and body surface area of greater than 10%. Complications and co-morbidities of psoriasis. Immune-mediated inflammatory diseases. Psoriatic arthritis is the most frequent inflammatory disease that is associated with psoriasis. The second commonest is inflammatory bowel disease that include both Crohn's and ulcerative colitis. Other immune-mediated disease include autoimmune thyroid disease and type 1 diabetes mellitus. There may be increased risk of alopecia areata, vitiligo, and urticaria, particularly in psoriatic arthritis. Infections. It has been long known that patients of psoriasis may carry staphylococci on their skin. Psoriasis, active psoriasis is a risk factor in patients undergoing hip or knee replacement surgeries in advanced psoriatic arthritis. So it is imperative that the skin psoriasis should be treated before going for joint surgeries. There is a known effect of streptococcal infection in triggering disease, particularly the guttate psoriasis. Psychological distress. Psoriasis is associated with many psychological effects like dysfunctional thoughts, pathological worrying, fear of stigmatization, effect on self-image, personality, and temperament. Excessive alcohol consumption has been found more commonly in men with severe psoriasis. Anxiety, depression, and suicidal thoughts are more common. Cancer. There are few reports of association of cancers with psoriasis. The strongest association is with non-melanoma skin cancers. High dose of PUVA known to increase the risk of cutaneous SCC and BCC, which may be compounded by the immunosuppressive therapy like cyclosporin, methotrexate, and tumor necrotic factor alpha. The narrowband UVB is relatively safe, but high-dose UVB may be implicated. There is a modestly increased risk of Hodgkin lymphoma in patients with psoriasis. Metabolic syndromes. The metabolic syndrome includes 4 syndromes: the hypertension, the hyperlipidemia, obesity, and diabetes. The prevalence of metabolic syndrome in psoriasis is 34% as compared to 26% in general population. The risk is highest in those with more extensive disease. The strongest of association is with obesity, and patients with BMI greater than 30 are more at risk of severe psoriasis. The psoriasis severity is also associated with insulin resistance, low energy diet, bariatric surgery, or decrease in weight is associated with improvement in psoriasis. Cardiovascular disease. Patients with severe psoriasis die at younger age than the unaffected population. Cardiovascular disease accounts for majority of excess mortality because psoriasis increases the risk of stroke and myocardial infarction. The risk appears greater in younger patients with more severe disease and with psoriatic arthritis. Much of the increased risk is associated with smoking and with concomitant metabolic syndromes. Treatment with psoriasis with methotrexates or tumor necrotic alpha reduces the frequency of cardiovascular events. Hepatobiliary disease. Non-alcoholic fatty liver is frequently seen in severe psoriasis in more than 50% of the patients. There is an association of obesity and metabolic syndromes in such cases. Alcoholic liver disease is also common because psoriatic patients are more prone to develop alcoholism. Neutrophilic cholangitis is a recognized disease seen in generalized pustular psoriasis. Other reported complications of psoriasis include acute respiratory distress syndrome that complicate erythrodermic or generalized pustular psoriasis. Psoriasis is also associated with increased risk of hyperuricemia and gout. Pregnancy outcome in patients with severe disease has high prevalence of adverse outcomes that include spontaneous abortion, preeclampsia, and low birth weight. Disease course and prognosis. Psoriasis is mainly a chronic and persistent disease that change very little over course of years. Environmental factors like infection, alcohol consumption, emotional stress, extreme of climates trigger the disease. Spontaneous remission occur between 1/3 and 1/2 of the patient that may persist for more than 54 years. Guttate attacks carry better prognosis and have longer remissions. Erythrodermic and pustular form carry appreciable mortality, and arthropathic form a considerable morbidity. Severe plaque psoriasis shorten the lifespan to 4 to 6 years in individuals of equal age and build who are non-psoriatics. Pustular psoriasis. The term pustular psoriasis is reserved for those forms of disease in which macropustules are seen, because micropustules are seen in all forms of psoriasis. So when the pustules are start appearing clinically, then this is called as the pustular psoriasis. Pustules may be provoked within the plaques of psoriasis as a part of unstable phase of a disease, and this condition is usually separated into a localized and a generalized form. Molecular genetics have revealed a mutation in IL-36RN protein. In localized disease, the disease is confined to hands and feet and tend to be chronic. In generalized form, the whole body is involved and disease is subacute, acute, or fulminating with a life-threatening course. Classification. The generalized pustular psoriasis is divided into two subtypes. The first based on morphology and natural history. This includes acute generalized pustular psoriasis of von-Zumbusch type and subacute annular and circinate pustular psoriasis. Then, based on age or the participants, this includes acute generalized pustular psoriasis of pregnancy and infantile or juvenile pustular psoriasis. Localized pustular psoriasis include Palmoplantar pustulosis and acrodermatitis continua of Halopio. Generalized pustular psoriasis. Generalized pustular psoriasis is characterized by a generalized sterile pustules. It is rare and extreme form of psoriasis, and all the main pathological features of disease are accentuated. The relationship between this entity and plaque psoriasis is a little doubtful, as some patients have phases of plaque psoriasis before they enter into the pustular stage. And there is another variety of patients who enter in the pustular phase of psoriasis without any preceding history of plaque psoriasis. This picture shows typical pustules arising on a background erythema. The pustules may coalesce to form lakes of pus. Incidence peak between 40 to 59 years, but infantile and juvenile cases have been reported. Women outnumber men by 2 to 1. Associated diseases include inflammatory polyarthritis, the metabolic syndromes, obesity seen in 43%, hypertension 26%, dyslipidemia 26%, and diabetes 24%. The predisposing factors. Environmental factors trigger the onset of pustular psoriasis, which include infections, topical or systemic treatments, psychological stress, pregnancy, and hypocalcemia. Both viral and bacterial infections are predisposing factors. The drug provocation is mostly by corticosteroids, especially with sudden withdrawal, and there are reports of induction by withdrawal of cyclosporin. In many instances, the acute generalized exanthemic pustulosis is confused with pustular psoriasis. Histologically, the pustular psoriasis are characterized by macropustules, and by macropustules it means the macropustules of Gogoj. Superficially, there will be parakeratosis and Monroe abscesses. The spongiform pustule of Gogoj will be dilated and bigger. The parakeratotic columns are associated with Monroe abscesses, and sometimes only subcorneal pustules are seen, with little or no epidermal hyperplasia. History. The acute stage is characterized by burning, painful sensation in skin. Fever and malaise is common with the development of waves of pustules, and half of the patient complains of, about third of the patient complain of arthralgia. The von Zumbusch variety of acute generalized pustular psoriasis has a more acute and severe form, and is clinically and genetically heterogeneous. It occurs as a sole phenotype or arise after the plaque psoriasis or after acrodermatitis continua or after palmoplantar pustulosis. It manifests only in pregnancy, where it is referred as impetigo herpetiformis, and sometimes as infantile and juvenile forms. The diagnostic criteria of generalized pustular psoriasis include recurrent episodes of fever and malaise, multiple isolated sterile pustules. Lab abnormalities include leukocytosis, increased ESR, increased C-reactive protein, and expanded Kogoj pustules on histopathology. There are two main groups which is distinguished. The first one, in which plaque psoriasis develop first, which convert later into pustular psoriasis, and second one, in which pustular psoriasis arise de novo. In either form, the eruptions are ushered by burning sensations and skin become dry and tender with high fever and malaise. Pre-existing plaque lesions become fiery and develop pinpoint pustules. Sheets of erythema and pustules spread to involve previously unaffected skin, flexures, and genital regions. Nail become thickened and separated by subungual lake of pus. Buccal mucosa and tongue is involved. Tongue show typical features of migratory glossitis. Remission may occur within days or week. Psoriasis return to a normal state or erythroderma develops. And relapses of pustular psoriasis are frequent. Then the second type is the subacute annular or arcuate generalized pustular psoriasis. Annular or other pattern of lesions may be seen in acute generalized pustular psoriasis, but this common presentation is seen in infant and early childhood. There are discrete areas of erythema which become raised and edematous, so centrifugal spread that may mimic erythema annulare centrifugum. Pustules appear peripherally on the crests of advancing edge. The systemic symptoms are absent. A related pattern is a recurrent circinate erythematous psoriasis. This is arcuate or annular psoriasis, pustular psoriasis. Impetigo herpetiformis, also known as the acute generalized pustular psoriasis of pregnancy. Rare genetic studies support the view that impetigo herpetiformis represent the generalized pustular psoriasis triggered by pregnancy. Onset is usually in last trimester, but can start earlier and even in puerperium, first day of puerperium. The disease tends to persist until the child is born and occasionally long afterwards. The features are essentially similar to that of generalized pustular psoriasis, with flexural onset and marked tendency of symmetry and grouping of pustules. Individual areas heal with reddish-brown pigmentation. Tongue and buccal mucosa and esophagus may show eroded or circinate lesions. Constitutional disturbances are characterized by fever, and death may occur due to cardiac or renal failure. Delirium, diarrhea, vomiting, and tetany are frequent complications. There is greater risk of placental insufficiency leading to stillbirth, neonatal death, or fetal abnormalities. Characteristically, the disease recurs in subsequent pregnancies. The fourth form of generalized pustular psoriasis is infantile or juvenile generalized pustular psoriasis. Generalized pustular psoriasis can begin at any age in childhood, but 25% of the cases have its onset in first year of life. Systemic symptoms are absent and spontaneous remission is possible. Pustular psoriasis may be localized to flexural area, neck for a long period of time. Severe form with fever and toxicity do occur, and this necessitates active treatment. Majority of patients with infantile or juvenile psoriasis is between 2 to 10 years. The disease can be of von Zumbusch type, that is a generalized disease, or can be of annular or circinate form. The differential diseases which comes in the differential diagnosis of generalized pustular psoriasis include AJEP, subcorneal pustular dermatosis of Sneddon and Wilkinson, infantile acropustulosis, acute pemphigus foliaceus. Sometimes the pustular lesions of bowel bypass surgery, Sweet syndrome and Behçet syndrome also resemble pustular psoriasis. Staphyloderma, severe impetigo, and candidiasis may also simulate pustular psoriasis. Severity of pustular psoriasis is judged mainly by arbitrarily by mild, moderate, or severe, and there is no validated scoring system. And this is based on the extent of erythema and pustulation, fever, and lab abnormalities like leukocytosis, increased ESR, low serum, and albumin. So based on these three criteria, the pustular psoriasis can be labeled as mild, moderate, or severe. Complications and comorbidities. Pustular psoriasis is a severe disease with many complications like hypovolemia and oligemia leading to kidney injury, hypoalbuminemia with sudden loss of proteins, hypocalcemia as a consequence of hypoalbuminemia and malabsorption, abnormality of liver enzymes, acute respiratory distress, staphylococcal infection, telogen effluvium, and amyloidosis. Disease course and prognosis. In absence of effective treatment, death occur in acute stage. There is apparent reduction in mortality because of the effective treatments, particularly after the introduction of retinoids, and reduced use of oral corticosteroids in psoriasis. Prognosis is good for subacute, annular, and circinate generalized pustular psoriasis and generalized pustular psoriasis of infants and childhood. The first of the localized pustular psoriasis is Palmoplantar pustulosis. That is characterized by erythematous scaly plaques which are studded with sterile pustules on palm and soles. Disease is chronic, resistant to treatment, and is probably a separate disease to plaque psoriasis. The prevalence is 0.01 to 0.05 in general population. Peak age 30 to 50. Women-men ratio 5 to 1. Associated disease is thyroid disease, and sometimes it is associated with anti-gliadin antibodies, and the patients improve on gluten-free diet. Palmoplantar pustulosis is a commonest cutaneous manifestation of Sappho syndrome, which is abbreviation of synovitis, acne, pustulosis, hyperostosis, and osteitis. Predisposing factor. Sometimes it starts de novo without any provocation. Cigarette smoking is reported to be strongly associated. While it is commonest morphologies on exposure to tumor necrotic factor inhibitor for treatment of rheumatoid arthritis or Crohn's disease. Itching is variable, and more often the patient complain of burning. Disease present as one or more well-formed plaques on thenar eminence, hypothenar eminence, central or distal palm, on instep of foot or medial or lateral border of foot or on the heel. Digital lesions are uncommon in palmoplantar pustulosis. Affected area is characterized by dusky red scaly plaques studded with numerous pustules, usually 2 to 5 millimeter. Fresh pustules are yellow, while the drier pustules are brownish in color. Normally, pustules are seen in all stages of evolution, so there are polymorphic lesions. Eventually, the pustules desiccate and exfoliate. Plaques of psoriasis may be present elsewhere on the body in minority of the patient, which are mild and atypical. This is the presentation of palmoplantar pustulosis, where you can see palmar skin and the heel, where there are pustules in different stages of evolution and polymorphic appearance. One of the clinical variant of palmoplantar pustulosis is pustular bacterate. The term is used for acute monomorphic eruption of pustules. All the pustules in this disease are in same stage of evolution, and in this way it is distinct from palmoplantar pustulosis. The term bacterate is used because it is thought to be provoked by some remote bacterial infection. Differential diagnosis of palmoplantar pustulosis include tinea, which is usually asymmetrical and unilateral, secondary infection of eczema, allergic contact dermatitis, and chronic acropustulosis seen in black infants. The course is prolonged, spread is slow and refractory to treatment. Sometimes spontaneous remission does occur, but it is often temporary than permanent. The second type of localized pustular psoriasis is acrodermatitis continua of Hallopio. This disease is different from palmoplantar pustulosis because it affects the tip of fingers and toes and slowly extend locally and may evolve into generalized pustular psoriasis. Patients of acrodermatitis continua of Hallopio do not have additional plaque psoriasis. This results in localized destruction of soft tissue, nail apparatus, and sometimes the bone. So they're mostly seen in children and young adults and more common in women. Histopathological features similar to that of pustular psoriasis. Onset is attributed to minor trauma and infection of tip of the digits and precipitated or aggravated by oral corticosteroid. First lesions start on finger or thumb more often than on toes. Skin of distal phalanx become red and scaly and pustules develop. Nail folds and nail bed is involved, leading to nail dystrophy. Proximal edge of the lesion is bordered by vesicular pustules. Nail plate is completely destroyed and bony changes occur with osteolysis. Free end of digits become tapered and wasted, just like we see in systemic sclerosis. Acrodermatitis continua may evolve into generalized pustular psoriasis, especially in elderly. So in this image, you can see the complete destruction of nails of all the fingers. However, the nails are retained on the thumbs. The differential diagnosis includes staphylococcal pulp infection, herpetic whitlow, contact dermatitis, candidiasis, and parakeratosis pustulosa. Course is prolonged, spread is slow, and refractory to treatment, as already mentioned. The last of the psoriatic variant is the psoriatic arthritis. Psoriatic arthritis is the seronegative inflammatory arthritis that occur in 40% of patients with moderate to severe psoriasis. The quality of life impairment and disease burden associated with psoriatic arthritis is similar to rheumatoid arthritis. There is a genetic susceptibility with increased risk among family members of both psoriasis and psoriatic arthritis. Casper criteria for psoriatic arthritis include the 5 criteria, and a point is given for each criteria. Patient must score 3 out of 5 to be labeled as psoriatic arthritis. The first criteria is the current psoriasis, and if the patient is suffering from psoriasis, then he straight away gets 2 score. If there is a personal history of psoriasis but no active psoriasis, then the score is 1. Or if there is a history of psoriasis in first degree relatives or second degree relative, then again score is 1. Second criteria is typical psoriatic nail involvement, have 1 score. A negative test for rheumatoid factor is again 1 score. Then dactylitis, current or history of dactylitis, both carry only 1 score. Then radiological evidence of juxta-articular new bone formation again carries 1 score. So a patient must score 3 out of 5 to be labeled as suffering from psoriatic arthritis. The psoriatic arthritis has 5 distinct types. The first one is the symmetrical polyarthritis that resembles rheumatoid arthritis involving the proximal interphalangeal joints, and 5 or more interphalangeal joints are involved, seen in 15 to 25% of, contributes to 15 to 25% of psoriatic arthritis. Asymmetrical oligoarthritis is the most common form of psoriatic arthritis, seen in more than 50% of the patients with four or less than four joints involved. Then more typical feature of psoriatic arthritis is the involvement of distal interphalangeal joint, but it is seen in only 5 to 10% of the patients. Spondylitis predominantly axial. Joints of spine and sacroiliac joints are usually asymmetrical changes seen in 20 to 50% of the cases. Then arthritis mutilans is seen in proximal and distal interphalangeal joints, and bones of the fingers show telescopic changes, move into one another. The first image is that of arthritis mutilans, second is of distal interphalangeal arthritis. The reported incidence is less than 0.01 and 0.25. Prevalence is 0.5 to 2.3 per 100,000, and it is associated with enthesitis, dactylitis, and more severe skin disease. Disease is equally divided between sexes. Majority of patients develop psoriatic arthritis before the age of 40. Childhood onset is rare. Majority of patients of psoriatic arthritis develop arthritis after having psoriasis for some years, and this contributes to 70% of the patients of psoriatic arthritis. In 20%, the joint disease starts before the skin disease, and in 10%, both the disease occur simultaneously. Associated disease. The psoriatic arthritis is usually associated with severe form of psoriasis, nail and scalp psoriasis. Ocular disease occur in 30% of the patients, and majority of the patients develop conjunctivitis, uveitis, iridocyclitis, keratoconjunctivitis sicca, and cataract. Association between psoriatic arthritis, obesity, metabolic syndrome, and alcohol misuse. Premature cardiovascular disease is also associated with psoriatic arthritis. The psoriatic arthritis is associated with many histocompatibility alleles, which include HLA-C6, HLA-B13, HLA-B27, B38, 39, B57, and DRB1. Presence of HLA-B27 or B39 is associated with simultaneous development of early joint and skin disease. Psoriatic arthritis is triggered by trauma to a joint or tendon, which is called as the deep Koebner effect. Cigarette smoking or excessive alcohol consumption is associated with psoriatic arthritis. HIV infection also initiates or worsens the disease. And similar to psoriasis, psoriatic arthritis is associated with obesity and metabolic syndromes. Pathophysiology is similar to pathophysiology of psoriasis, with immune activation in synovium and enthesis of the joints. There is increase in cytokines, tumor necrotic factor alpha, interleukin 17 and 23, but less so as compared to the skin. Angiogenesis is seen more in psoriatic arthritis than in rheumatoid arthritis. Clinical features. Symptoms of inflammatory joint disease, that is early morning stiffness and joint swelling, should be ascertained. Early morning back stiffness may be the only clinical feature of sacroiliitis and cervical spondylitis. Heel pain is a manifestation of enthesitis of Achilles tendon, and plantar fasciitis may be a presenting feature. The clinical examination may reveal evidence of dactylitis, that is sausage-shaped fingers, swollen or tender joints. This may affect one joint in asymmetric pattern or several joints simultaneously. Nail changes of psoriasis is seen in 80% of patients with psoriatic arthritis. There are several screening questionnaires that developed to assist the early diagnosis of psoriatic arthritis. This include psoriatic arthritis screening evaluation, the psoriasis epidemiological screening tool, and Toronto arthritis screening questionnaire. DD of psoriatic arthritis include rheumatoid arthritis, ankylosing spondylitis, gout, osteoarthritis, and fibromyalgia. Classification of severity is assessed by American College of Rheumatology, ACR, tender and swollen joint count. The ACR 20 refers to the 20% improvement in swollen or tender joint. ACR 50 or ACR 70 refers to 50 to 70% improvement. Disease activity score is calculated by using swollen and painful joint scores together with measurement of ESR. The psoriatic arthritis response criteria is defined as specified involvement of two of the following four key measures: patient global assessment, physician global assessment, tender joint, and swollen joints. I thank you all for a patient listening and see you next time with another version of the same topic, that is the management of psoriasis and its clinical variant. Thank you all.